COVID-19 has a wide variety of presentations, ranging from causing infection but having no symptoms for many patients, to patients becoming dramatically ill in a very short period of time. For those patients who get sick quickly, their disease begins with respiratory failure, and that respiratory failure progresses very rapidly. As it turns out, one of the first things to happen in a serious COVID-19 infection is dysregulation of the pulmonary vasculature, causing a profound hypoxemia that's associated with air hunger, much like someone who's just been exercising, but no dyspnea or difficulty in breathing. Because the alveolar air spaces are preserved early in the disease, the management for patients with COVID-19 differs than that from respiratory failure that we're used to seeing. Conceivably, managing respiratory failure in patients with COVID-19 in the same way one would do with ARDS could make them worse. In the April 24, 2020 issue of JAMA, an Insights article was published that was written by Dr. John Marini from the University of Minnesota and Dr. Luciano Gattinoni from the University of Göttingen, two respected experts on ventilatory management. I spoke with Dr. Marini, who reviewed the nuances of respiratory failure in the COVID-19 patient and how to manage it.
From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host, Ed Livingston.
You've written a JAMA Insights article about ventilatory management of the COVID patient. Could we start by having you tell us what the pathophysiology is of lung disease in COVID and how it affects patient management?
From all appearances that are coming in from data that are reported from clinical observations, from radiological information, from autopsy information, COVID-19 is a vasogenic problem. With respect to the lung, the damage appears to be primarily from the vascular side in the early stages anyway, and that transitions into a more traditional form of ARDS later. Now, these patients, as I think you know, begin to present with shortness of breath and high minute ventilations. The shortness of breath may not be accentuated in the beginning. They may not feel a great deal of dyspnea or difficulty breathing, but they are breathing fast, and they're breathing fast and they have very low oxygen saturations and very low oxygen tensions. That hypoxia is part of the stimulus to drive breathing, but is probably not the whole reason. But the profound hypoxemia certainly causes discomfort in the patient and is what prompts them to get emergent attention from the hospital setting. These kinds of problems surface usually several days after the onset of recognizable first symptoms of the disease. The patient doesn't feel quite well. They may have other associated symptoms, but they're not dyspneic in the beginning. They come to the hospital when the hypoxia is a cause of discomfort or concern. They don't know it's hypoxia, but does drive ventilation. They're breathing heavy. They may describe some shortness of breath, but it's the kind of shortness of breath you get when you exercise, and not something that tells you that you just can't pull the lung open. I think in the later stage, it transforms to a more traditional form of lung injury called acute respiratory distress syndrome and can be treated at that point somewhat differently.
Can you tell us a little bit more about the distinction between the two types of shortness of breath? What does a patient tell you when they come in with this sort of COVID-related shortness of breath versus shortness of breath from, say, congestive heart failure or the kind of pulmonary edema we're used to seeing in other diseases?
Well, obviously that's highly variable with the patient. They may describe that they're short of breath, but not necessarily that they're having asphyxic type of breathing, very difficult to draw each breath. They know that they're breathing faster. They know that they're catching up with something, but they're not accomplishing normal lung function. Later, of course, the patient is in overt distress, and that distress is recognizable to the patient in terms of just difficult to draw the breath and a certain anxiety or desperation that they may not be able to continue.
One of the things you wrote about are the different appearances of x-rays in these patients. There's a ground glass appearance versus other types. Could you tell us a little bit about what you see on plain radiographs or CT images of COVID patients versus other kinds of respiratory failure?
On a routine chest x-ray, you may see very few infiltrates initially, although the patient is profoundly hypoxemic and breathing at a high rate. They may not have really anything that resembles traditional ARDS. However, if you do a CT scan, as you mentioned, you may see scattered ground glass infiltrates that are often scattered, sometimes very few in the beginning. And that ground glass appearance is characteristic of interstitial edema, not flooding of the alveoli like you ordinarily associate with a full-blown traditional ARDS.
In your article, you discuss a very different pathophysiologic mechanism for COVID disease. It involves dysregulation of the pulmonary vasculature. Could you tell us more about that?
Absolutely, and you're quite correct. Initially, the problem is not with the air spaces as much as it is with what would be called vasoplegia if it happened in the periphery, and sometimes we associate that term with sepsis, particularly sepsis that's refractory to vasoconstrictors. Now, in the lung, we believe that there is evidence of vasoplegia, and some recent X-ray evidence coming from quantitative CTs and sophisticated imaging techniques is very consistent with that interpretation. The lung has a vasoplegia, which means that it cannot regulate the perfusion to match ventilation. And when that happens, both hypoxemia and the inability to ventilate appropriately happens because the whole carbon dioxide load cannot be handled by the piece of the lung that is being ventilated. That's the initial stage of what we call CARDS, C-A-R-D-S. And when I say we here, I mean my co-author Luciano Gattinoni and I are talking of a process that on one extreme is mainly vasoplegia and has minimal infiltrates, relatively good compliance, and we call that type L, which means that they don't need a lot of PEEP. And in fact, if you put on the traditional PEEP on these people in the early phase, they may redirect blood flow adversely in the lung and cause even more trouble. Later on, they behave more like the airspace-filled atelectatic ARDS patient that we customarily use high levels of PEEP in and other measures that try to open the lung. In the beginning, it's the mistake to push the PEEP.
There's a concept that you discussed in the article about patient-induced lung injury that results from excessive respiratory effort. Could you tell us more about that?
Yes, this is not original with us, the term P-SILI. Interesting choice of a mnemonic, but it's P-SILI to contrast with VILI. In other words, the patient-induced lung injury versus ventilator-induced lung injury, which suggests the latter is a physician choice. These patients, when they start to pump hard, trying to breathe hard and take strong efforts, they generate a negative force that surrounds the lung. And what that does is it does two very detrimental things. One, it puts strain on the lung tissue. From the airspace side, they may exceed the strain limit of the individual air sacs, and they will leak just as they would if you applied positive pressure and the patient was not breathing at all. They contribute to the total pressure across the passive lung. So when they do that piece of it, which is bad enough and has been described before. But there's also another piece, and that piece is the vascular side piece, which is actually fundamental to this disease. When you pull hard with negative pressure, spontaneous breathing is the way you do that, you increase the blood flows through the lung, and you increase the vascular pressures associated with those high cardiac outputs. And what that means is that you have the lung being attacked from two sides. One, the airspace side of the extra stretch, and the other, in COVID, You have the vascular trauma that is what you might say is endothelial trauma versus epithelial trauma. That is accelerating the problem, and we call that a villi vortex. In other words, you keep on matching those things up with each other. They reinforce each other. They damage the lung. Some lung units go out of commission, and you're left with a baby lung that is associated with traditional ARDS. A baby lung is a small capacity lung, and it has to perform all the high minute ventilation. It has to accept all the stresses, all the blood flow that is matched up with airspace, and there's a potential for progression of that down what we call a villi vortex. That, I think, is a new term, but it calls to mind what you're dealing with here. If you don't interrupt that cycle, the patient will get catastrophically ill.
Preventing a patient from developing respiratory distress or expending too much energy and effort into breathing is a high priority for managing COVID patients. So what should clinicians do to avoid that situation?
Well, I think logically, if the mechanism is kept in mind, the potential treatments come to mind as well. You don't want the patient forcefully breathing, and you don't want high cardiac outputs. You don't want to put a lot of energy and power into the lung, which can be damaging. You don't want to have a lot of blood flow going through the lung, which can accelerate that problem. So a clinician would try to minimize the need to breathe forcefully and to address unnecessary oxygen demands. If I were calling the top things to mind, I would say avoid agitation, avoid dyspnea. In this case, you don't want to have high fever. You want to suppress a fever. The most important thing is you don't want them to be in pain or agitation or any unnecessary need to breathe forcefully. And if they do breathe forcefully, you need to intervene.
Does that translate into having a low threshold to intubate these patients as they start to get more ill?
Indeed, it does. Some have argued that we should try first nasal oxygen and high-flow nasal oxygen and non-invasive ventilation, etc. Absolutely, if they're monitored closely and the patient's efforts are being looked at in one way or another, either with clinical signs or if you're sophisticated by esophageal balloons or another method to quantitatively look at effort. But the main thing is to avoid that deteriorating cycle and avoid those strenuous efforts. Those are keys.
The unfortunate reality is that a lot of non-expert clinicians will be managing these patients, whether they're in smaller community hospitals who are not familiar with the latest thinking about these problems, or in very busy centers where there's been staffing shortages and clinicians who are not usually managing intensive care patients have that responsibility. So could you, in sort of a basic way, walk us through how you set up the ventilation parameters for an intubated patient who has COVID, specifically like the tidal volume, the PEEP, FiO2, what your goals are in terms of FiO2 and CO2, and maybe compare that to the usual ARDS patient that we're used to?
I think that we are always trying to get the FiO2 down to lowest acceptable level in almost all patients. And that applies also to the COVID patients. So I would not be shy about giving higher levels of inspired oxygen, especially in the beginning, because the problem, although it isn't really the hypoxia that's the problem, that can be usually corrected. You should use whatever FiO2, inspired oxygen fraction, that you need to get a good solid oxygen saturation. You do not want to enforce a carbon dioxide level that's normal. This has been known for a long time, called permissive hypercapnia. In other words, if you can allow the patient to have a slightly higher CO2, maybe not 40, maybe something closer to 50 or 60 millimeters of mercury, and not provoke forceful breathing, in doing so, you should allow that to happen. And setting up the ventilator parameters, once you've assigned patient the non-invasive ventilation, I would certainly think that you start off with a fairly low PEEP level, and you may use what's called the driving pressure of between 3 and 11 or even 12 centimeters of water, if that calms the patient down with non-invasive ventilation. Now, once you've decided that the patient's efforts are extreme and the patient needs to be intubated, then deep sedation, paralytics, if necessary, to stop the vigorous breathing and to take control of the situation. The tidal volume, in the very early stage, you may find, as we almost all do and has been reported, that the driving pressure is actually very acceptable, well within safety limits, so to speak, for ARDS, not caused by COVID. The tidal volumes should be adequate to give you a carbon dioxide level that is acceptable to the clinician, which would be, as I said, usually in the range of 50 to 60, assuming they don't have another reason for metabolic acidosis. Later, the guidelines of lung protective ventilation go in force. You don't want the pressures, particularly the plateau pressure and the driving pressure, to exceed recommended limits. But that's at a later phase. That's in a patient who's been sick for a while and presents with what appears to be typical ARDS. What we've been talking here about is here's a patient not too many days in that presents first with one type phenotype and then merges toward a more traditional approach where you would use prone positioning. And if nothing else works to achieve acceptable gas exchange and to keep the patient's situation stabilized as far as oxygenation is concerned, even after using prone positioning, then of course extracorporeal assistance is valuable.
You mentioned the driving pressure. What's that?
Yes, I apologize. This is not terminology that everyone knows. It is, in each tidal breath, there's a difference between the highest alveolar pressure that you see, which we typically call the plateau pressure. And that, let's say, safe upper limit for that may be 25, maybe 30, depending on the stiffness of the chest wall, if you're only measuring airway pressure. That's the plateau pressure. That's the high. The low is the total PEEP. That's PEEP plus auto PEEP on the low side. So the driving pressure is the difference between them. And that's a component that's very important and part of the dynamic energy of each cycle, part of the dynamic power, meaning the number of cycles and the frequency per minute that we think is instrumental to the airspace injury of villi, the traditional villi. Of course, if the patient is triggering the ventilator, you know what you're putting in terms of airspace pressure, but you don't know what's on the other side of the lung if the patient is breathing by themselves.
In your article, you had specific recommendations for tidal volumes for COVID patients or these CARDS patients in contrast to ARDS patients. What are those differences in the tidal volume recommendations?
Sure. If you're talking about a traditional patient, you would be looking at what's called a lung protective tidal volume, which in fact is not what we should be focusing on. We should be focusing on the transalveolar pressures, but we use tidal volume, which is associated with driving pressure in any given patient. If you have a patient on the beginning side of the ventilation, if they have good compliance, then you can liberalize a little bit in the range of 7 to 9 milliliters per kilogram of predicted body weight, or some people call it ideal body weight. If you're dealing with a patient who's more advanced and resembles more traditional ARDS, you would target 5 to 7 ml per kilogram. These are approximations, and of course the compliance of the patient's chest wall, as well as the size of the functional lung, the baby lung, will determine what's appropriate. The important thing is you don't want to go over those pressure limits, and the tidal volumes that you choose should be selected with those ideas in mind.
Given what you've just told us, what are the research priorities for the immediate future to learn how to better manage these patients?
The research priorities are, of course, we're all interested in treatments, which there are some promising developments there. That's an entirely different area. The research related to mechanical ventilation in these folks, I think, would have to deal with defining how much is the vasoplegia that I began to speak about and how much is the later thrombosis causing the dead space, the high ventilation requirements that they have. I think everyone listening to this probably knows what dead space is, but I'll just remind them it's ventilation in excess of perfusion. That adds to the strains that have to be put on the lung from both the airspace and the vascular side. And we want to avoid that dead space. The situation here is one of disrupted vasoregulation in the beginning, or in mild cases, that doesn't necessarily progress, but if it does, it will interface the vascular stresses with the airspace stresses, and then the lung becomes the engine. It's very possible that the lung, which receives all the blood flow, becomes the engine of the cytokine storms that people are talking about as the cause of death. It's, of course, speculation. It's a research topic. But I should say that we know from autopsy results that patients who do die have circulating endothelial cells, basically ripped off the vascular inner membrane and circulating in the bloodstream, and those can provoke in other organs trouble, the liberation of inflammatory cytokines that make dysfunction, that then creates more of a problem, even creates systemic vasoplegia and inability to respond to vasoconstrictors. At what stage are we when we see somebody breathing heavily? What are reliable signs that you're at the early stage, the vasoplegic stage, or the thrombus-inducing stage, which tends to happen with high frequency, especially later on? Because then you can use non-ventilatory treatments to interrupt the progression to thrombosis and interrupt the potential for a cytokine storm.
I think we've covered most of what's in the article that's in JAMA. Do you have any final thoughts or other areas that we didn't cover that you think our listeners need to know about?
I think we have covered a wide area, and I would emphasize that we want to intervene early, prevent the forceful breathing, pay attention to the vascular side, reduce the oxygen demand that's unnecessary, and have a low threshold for reducing the patient's efforts and quieting them. The thing I would like to call attention to in closing is in weaning, these principles are important too, because the patient can backslide into a villi vortex on the weaning side of things, as well as on the initial pre-intubation phase. That, to me, is very important. We need to keep them quiet for as long as possible until we know that the patient is definitely making progress. Don't make abrupt transitions in cares. Don't do some of the usual things like spontaneous breathing trials on a daily basis. That means an interruption in support. Be very careful with the supports. This villi vortex business, not everybody may agree with it, but we call it the shrinking baby lung. And the small aerated compartment that performs all the gas exchange is what we're trying to preserve and expand. And if we don't pay attention to forceful efforts and pressures that we're using, etc., we will have a shrinking baby lung and more load put on, more intensity and difficulty. So early intervention and caution in weaning.
One of the things I've been asked about in terms of research is ECMO. You mentioned ECMO before, but is this a clinical situation where early ECMO management might be beneficial because of the pathophysiology that you've just described? It seems like the lung just needs to get over it without being destroyed by our efforts to maintain oxygenation and other gas parameters.
You're asking an excellent question, Ed, and that is a research question as well. If you follow the principles, or if one follows the principles of avoiding the villi vortex and intervening early, yes, it makes very good sense for those centers who are expert at it. It just as much for the offloading of the CO2 load that the lung has to deal with as for improved oxygenation. Certainly, extracorporeal supports have now become mainstream, but I would say that's only happened over the last 5 years or so, that it's become a widespread, acceptable rescue form of treatment. Try to do almost everything else before you do that, but don't wait very long if you're losing the game.
Any final thoughts from you?
We are defining new principles. We're working scientifically in cooperative ways that are unheard of. The high technology age has its downsides, but it has certainly facilitated communication and liberation and cooperation. And I think that it's a wonderful thing that we have available such things as podcasts, webcasts, and other electronic media that get this information out soon.
I'd like to thank you for, one, writing the article so quickly, and two, taking the time to talk with us here at JAMA. This has been informative and important. We hope that clinicians can use this in their management of these patients.
It's a great privilege, Ed. You've helped immensely. Thank you.
Great. Thanks, John. It's important to recognize that the basic cause for hypoxia in COVID-19 patients is vascular dysregulation and not alveolar edema. Because of that, the early phases of respiratory management for these patients is different than it would be for ARDS. Treating patients with COVID-related respiratory failure the same way one would do with ARDS, for example, by using high levels of PEEP and leaving patients with some element of respiratory effort might make them worse. It's important in the early stages of COVID-19 respiratory failure to use somewhat higher tidal volumes, not much PEEP, and tolerate a somewhat higher CO2 level than usual. It's very important to rest the patient's lungs and avoid any excessive respiratory effort, which can worsen the pulmonary condition of a COVID-19 patient. I'd like to thank Drs. Marini and Gattinoni for writing the JAMA Insights article on management of COVID-19 respiratory distress, and Dr. Marini for spending time to talk with us here at JAMA Clinical Reviews about this important clinical problem. I'm Ed Livingston, Deputy Editor for Clinical Reviews and Education at JAMA. Thanks for listening.